Let's now talk about the posterior uveitis. Okay, so posterior uveitis is the most common cause of the posterior uveitis in adults is toxoplasmosis, and this was followed by the retinal vasculitis. What will be the clinical features? What we already mentioned them in the beginning of the lecture, but we will just stress on them again. It can be present with inflammation of either the vitreous, the blood vessels, the retina, and the choroid. The vitreous inflammation will present with vitreous cells, membrane, opacities, inflammatory exudation such as snowballs. Vasculitis will present with opacifications around the blood vessels, what we call sheathing. Sheathing if the whole vessel is involved, or cuffing if a segment of the vessel is involved. Also, there will be exudation around the blood vessels, what's called candle wax dripping. Retinitis with pigmentary changes occurs due to RPE inflammation. Choroiditis can be focal, multifocal, or diffuse choroidal detachment also can occur. The complications of posterior uveitis can be either neovascularization, cystoid macular edema, optic nerve swelling and atrophy, cystoid macular edema, which is a common cause of vision loss in parasymptomitis and retinal vasculitis. Cystoid macular edema, importantly, doesn't occur in Vogt-Koyanagi-Harada syndrome. So to classify the posterior uveitis again to infectious and non-infectious, for the infections will be the toxoplasmosis and the toxocariasis, viral such as cytomegalovirus retinitis, acute retinal necrosis and the progressive outer retinal necrosis, fungal such as presumed ocular histoplasmosis and the candida, syphilis, Lyme disease, and the propionibacterium acne. For the non-infectious, it will be the sarcoidosis, Vogt-Koyanagi-Harada disease, Behçet disease, retinal vasculitis. So for the toxoplasmosis and toxocariasis have been already covered in the pediatric ophthalmology. We will start by the most commonly asked in the exams, which is the viral posterior uveitis. Starting by the cytomegalovirus retinitis. Cytomegalovirus retinitis is the most common ocular opportunistic infections in patients with the HIV infection or AIDS infection. Those patients will have the progressive hemorrhagic necrotizing retinitis involving the all retinal layers. It specifically occurs when the patients have very low immunity, like when the CD4 count falls below 50 cells per millimeter per cubic millimeter. And this table will show you what will be the diseases which are the eye will be at risk when depending on the CD count, this CD4 count. So when usually it will be, or the normal, it will be more than 500. If it is below between 250 and 500, the patient will be at risk of developing herpes zoster ophthalmicus and tuberculosis. If it falls between 150 to 250, the patient will be at risk of lymphoma and the Kaposi sarcoma. Between 50 to 150, the patient will be at risk of pneumocystosis, toxoplasmosis, microsporidosis, varicella zoster virus retinitis. If it is less than 50, then this means that the patient will be at risk of cytomegalovirus retinitis. So this will be the commonest opportunistic infection that involves the retina when the CD4 count falls below 50 cells per millimeter square or cubic millimeter. 40% of those patients will be having bilateral presentation. The clinical feature, those patients, the strange thing about those patients that sometimes they are asymptomatic. Especially when the lesions are involving the retinal periphery. So in the questions, in the scenario, in the exam, they will tell you that the patient has floaters. So this is the commonest feature or the commonest complaint for those patients, floaters, which doesn't reflect the seriousness of this condition. Also, if it involves area near the macula, those patients could complain of scotoma. There will be again mild anterior chamber and vitreous reaction. So this is again something could be strange. Why those patients have mild reaction despite the severe hemorrhagic necrosis of the retina? Because the reaction always reflect the immunity. If the patient has high immunity, then you will have severe reaction. If there is low immunity or minimal immunity, as in those patients with CD4 count less than 50, they will have minimal reaction. So when we have these findings in a patient with HIV, we suspect a cytomegalovirus retinitis, which can present or can be present clinically in one of the two forms. Either what's called brush fire appearance, appears as granular yellowish white lesions of hemorrhagic necrotizing retinitis from the periphery, present from the periphery with what's called peripheral atrophic burnt out region, or can be present with pizza pie fundus, in which there is thick yellowish white necrosis of the retina with hemorrhage and vascular sheathing, giving the pattern of like a pizza. So what will be the treatment? The treatment should be initiated immediately by the antiviral therapy. So there will be like a pulse dose followed by maintenance dose. And there are different antiviral medications that you should know about and should know what will be the main side effect and the main systematic toxicity that can occur from each one. The ganciclovir will cause bone marrow suppression. The foscarnet and cidofovir will cause renal toxicity. The valganciclovir will cause bone marrow suppression. So the ganciclovir and its derivative, the valganciclovir, both of them will cause bone marrow suppression. The foscarnet and the cidofovir will cause renal toxicity. There is a very important advantage of the valganciclovir here, which is it is oral medication. So unlike other medications, it will be the only one that can be administered orally. Also, we can supplement the systemic antiviral therapy by intravitreal injection of the antiviral, especially in sight-threatening lesions or if there is systematic toxicity, such as by intravitreal injection or intravitreal implants of ganciclovir and foscarnet. And the surgery will be by implanting the ganciclovir implant or by doing retinal detachment repair for patients who develop retinal detachment. So this should be given together with the treatment of the HIV, which is called the HART therapy or highly active antiretroviral therapy. Okay, so we give this treatment together with the HART therapy, and we expect that the patient could improve. However, their patient can improve, but all of the sudden show sudden worsening. And the worsening is not due to the virus or not due to the HIV or not due to the cytomegalovirus, but it is due to the treatment itself. This is what's called the ocular immune reconstitution inflammatory syndrome. So this is like a kind of reactivation of the immune system after suppression of the infection and the inflammation that will result in that this immune system will cause uveitis itself. So occurs when with the cytomegalovirus retinitis following the induction of highly active antiretroviral therapy. It is mediated by the recovery of immune response specific to residual cytomegalovirus antigen located in the eye. So this means that when the patient had cytomegalovirus infection into the eye, the immune system was weak, so the immune system didn't initiate any autoimmune response toward this virus. However, after controlling of the inflammation or controlling of the improving the immunity with the highly active antiretroviral therapy, the immune system start to wake up again and recognize the presence of viral antigen in the eye. So the immune system will attack it. This attacking of the virus will result in inflammation or uveitis. So what will be the risk factors for developing of this ocular immune reconstitution inflammatory syndrome beside the improved immunity? It will be the presence of low CD4 count at the time of initiation of HART therapy, the involvement of larger proportion of the retina, meaning a larger number of cells infected with the cytomegalovirus, and the treatment with the cidofovir specifically have been associated with high incidence of ocular immune reconstitution inflammatory syndrome. So this immune recovery uveitis is a major cause of visual loss and morbidity among patients with HIV who are receiving the heart therapy. Another form of viral uveitis, viral retinitis, called acute retinal necrosis. So in acute retinal necrosis, there is presence of acute confluent peripheral necrotizing retinitis, which occurs due to varicella zoster virus, herpes simplex virus, or rarely the cytomegalovirus. So what will make it different from the cytomegalovirus retinitis is that it usually occurs in immunocompetent individuals. So those patients will be usually immunocompetent, caused by varicella zoster virus or herpes simplex virus, and around 33% of patients are bilateral. And since that this occurs, or this disease occurs in immunocompetent individuals, this will give you a hint about the nature of the disease. There will be intense inflammation, there will be ocular pain, periocular inflammation, pain on the eye movement, redness, photophobia, floaters, decreased vision, constriction of the visual field. Regarding the signs, the patient will have diffuse episcleral injection, mild iritis, granulomatous keratic precipitates, and vitritis, with the retina showing peripheral patches of necrotizing retinitis that become confluent. So these patches of retinitis later on become confluent, with generalized obliteration of retinal arteries, with peripheral vasoocclusion and pale disc edema. So the treatment of those patients should be initiation of systematic antiviral therapy. And the prognosis, usually the fellow eye, we need to watch closely the fellow eye, because usually it will develop acute retinal necrosis within 4 weeks. This is a very serious and very aggressive condition. But prompt treatment and recognizing the problem from the start, recognizing that this is an acute retinal necrosis, this will reduce the risk of by 50%, and like 65 to 90% of those patients will develop rheumatogenic retinal detachment. Severe inflammation will result in retinal breaks, causing retinal detachment. So in this case, those should be treated by vitrectomy, and this usually occurs within 3 months. If the patient, or after usually within 2 months, this disease may settle down, so the retinitis will gradually resolve and the necrotic retina will slough, so leading to eventually like a coarse salt and pepper pigmentation. So the retina will show some pigmentations like a salt and pepper. Another form of viral retinitis is called the progressive outer retinal necrosis. This is another variant of acute retinal necrosis, but occurs in HIV patients. So those patients will, again, since that they have HIV, so they don't have immunity, they will be painless with minimal intraocular inflammation, and often with a history of cutaneous zoster. So those patients usually, or the progressive outer retinal necrosis, usually is due to the varicella zoster virus. So varicella zoster virus can cause acute retinal necrosis in immunocompetent or progressive outer retinal necrosis in immunocompromised or HIV patients. 74 patients are unilateral presentation, while 70% becoming bilateral. The clinical feature, there will be multiple discrete peripheral or central retinal opacifications or infiltration with very rapid progression. You see, this is after 5 days of the same patient has multiple areas of retinal opacification, and after 5 days become confluent, become very progressive. But here vasculitis are not prominent. So you can see there is no hemorrhage here, there is no vasculitis. Treatment of those patients, unlike the acute retinal necrosis, will show poor response to antivirals. 67% of those patients will become no light perception within 4 weeks, and retinal detachment also occurs in 90% of patients. Okay. So here now we covered the viral retinitis. It will be including the cytomegalovirus retinitis and the acute retinal necrosis and the progressive outer retinal necrosis. Other causes of uveitis, it will be the Propionibacterium acne. In the Propionibacterium acne, we also talked about it in the cataract. It is a gram-positive rod. It is anaerobic, which can be sequestrated within the capsular bag following cataract surgery. It has a delayed onset, causing chronic or delayed onset endophthalmitis, which will be present also with chronic granulomatous uveitis, usually with hypopyon or fibrin. There is whitish plaque in the posterior capsule. This is very characteristic. Treatment for this case will be intravitreal antibiotics such as vancomycin or cephalosporins. This drug or this organism is resistant to aminoglycosides, but usually they are not very effective because the organism is already enclosed within the capsular bag, making it immune from the effect of the antibiotics. So usually the treatment should be partial or total removal of the capsular bag with or without intraocular lens removal or exchange. Another infectious cause of posterior uveitis and panuveitis, it's called the Lyme disease. Lyme disease is caused by a spirochete called the Borrelia burgdorferi that is transmitted by deer tick. So this is the organism, or this is the insect that will carry the organism, the spirochete Borrelia burgdorferi, and when the patient when the deer tick will affect the individual, the patient, or this insect will bite the patient, this will result in characteristic features of Lyme disease, which will pass into 3 stages. Regarding the systemic features, it will start by a macular rash called or known as erythema chronica migrans. So at the site of the tick bite, there will be characteristic rash, takes like a round or macular rash called erythema chronica migrans, together with general constitutional manifestations such as fever, malaise, and fatigue. Then the patient will proceed to the second stage, which is secondary erythema chronica migrans rash, together with the CNS, joints, and heart affection. And in the stage 3, it will be present with chronic arthritis. Regarding the ocular features, in stage 1, with the erythema chronica migrans rash, there will be only follicular conjunctivitis. So this will be the first stage ocular features. In the second stage, this will be present with anterior uveitis, the most commonly intermediate uveitis with these snowballs and snow banking, posterior uveitis or panuveitis. The vitritis could be severe and accompanied by granulomatous anterior chamber reaction, papillitis, neuroretritis, choroiditis, retinal vasculitis, and exudative retinal detachment. So the most commonly, or the most kind, or the most prominent inflammation in the Lyme disease occurs in the second stage. In the third stage, the intraocular inflammation becomes less than stage 2, but the keratitis become more common. How to diagnose Lyme disease is by investigations such as ELISA for the specific immunoglobulin M and G against the Lyme disease, and the treatment for this Borrelia burgdorferi will be oral antibiotics such as amoxicillin, doxycycline, cefuroxime, or intravenous ceftriaxone. Another infectious cause of posterior uveitis called the cat scratch disease. The cat scratch disease is caused by the organism called Bartonella hinsali. Bartonella hinsali also cause the other cause of chronic follicular conjunctivitis called the oculoglandular syndrome. So oculoglandular syndrome, cat scratch disease, both are caused by Bartonella hinsali. Those patients could have retinal granuloma or neuroretinitis. Neuroretinitis present with optic disc swelling and macular star. So those patients are, these are the manifestations of cat scratch disease. To diagnose it, we need also ELISA for specific IgM and IgG, and the treatment will be with oral antibiotics such as doxycycline and rifampicin. Syphilis, we cannot ignore or we cannot overlook the syphilis as a greater masquerade. Syphilis is called the greater masquerade or the greater mimic because it can mimic any case of uveitis. So if you want to put a differential diagnosis for any case of uveitis, just to put the syphilis. It can cause virtually anything. The syphilis is caused by the spirochete called the Treponema pallidum. Regarding the ocular features, it can be it will be different whether it is acquired syphilis or it is a congenital syphilis. For the acquired syphilis, the ocular manifestations occurs with a secondary or tertiary syphilis, because the primary syphilis will be more of a genital lesion. So secondary and tertiary syphilis are characterized by presence of panuveitis, iris papules, gummata, which appears as yellowish red nodules, chorioretritis or salt and pepper changes, optic neuritis, ischemic optic neuropathy, optic atrophy, and argyropersum pupil, ectopia lentis, and interstitial keratitis. So we discussed all this, like optic neuritis, ischemic optic neuropathy, argyropersum pupil, interstitial keratitis. We said that they can be caused by syphilis. In congenital, we said also that interstitial keratitis can be caused by both congenital and acquired syphilis, anterior uveitis, ectopia lentis, argyropersum pupil, optic atrophy, and chorioretritis. So how will we investigate the syphilis? It will be by serology, by VDRL, by venereal disease research laboratory, or rapid plasma reagent, or and fluorescent treponemal antibodies. It will be also helpful for diagnosis of syphilis. If there is suspicious of neurosyphilis, we need to do lumbar puncture. The treatment of syphilis will be by penicillin G. But if the patient is allergic to penicillin, then the treatment will be by doxycycline or erythromycin. The next cause of infectious posterior uveitis will be the candidiasis or the fungal endophthalmitis. The fungal endophthalmitis occurs in patients who are immune suppressed or debilitated patients. Usually those patients are in the ICU or are terminal patients, like after terminal patients, terminal cancer, or those patients are receiving immunosuppressive medications for renal transplant, for example. So those patients are usually on hyperalimentations or intravenous drug abusers. So this will result in that this hyperalimentation or intravenous drug abuse will result in entry of the fungus candida into the bloodstream, and then it will reach the retina. But however, in most cases, there is no positive blood culture or ongoing fungemia. So the fungus cannot be readily detected in the blood. And 10% of those patients with candidemia will develop endophthalmitis. So those patients will have anterior uveitis, retinal hemorrhage, perivascular sheathing, like any posterior uveitis, chorioretritis, with the characteristic lesion here is the fluffy white lesion, cotton balls. So cotton balls are these whitish lesions present due to the candidiasis. So don't confuse the cotton balls from the snowballs. Snowballs occurs with the vitritis in intermediate uveitis, while cotton balls occurs due to candidiasis. So this is the characteristic lesion. Also, there could be some vitreous abscesses or subretinal abscess. Investigations, we need to do culture on blood agar or Sabaro agar. So we can take a sample and then culture it from the blood on the blood agar or Sabaro dextrose agar. Treatment should be initiated by the intravenous amphotericin B as an antifungal, but watch out for the toxicity. And prognosis, like those patients already have poor general conditions, so usually they have 70% mortality within 1 year. Speaking about the fungal infection, then there is another fungus which can affect the eye called the histoplasma capsulatum. It will result in a clinical syndrome called the presumed ocular histoplasmosis syndrome. What is the presumed ocular histoplasmosis syndrome? It is a histoplasmosis caused by a fungus called the histoplasma capsulatum. It has 5 characteristic ocular features. First of all, these characteristic lesions called the histospots. These histospots are chorioretinal scars, multiple, small, rounded, depigmented, and atrophic. These are called atrophic histospots. Sometimes they are scattered throughout the posterior pole and appears as a linear streak. It is called the histostreak. This is the histostreak in the posterior pole. They will also be present with peripapillary atrophy. This is one of the differential diagnoses of peripapillary atrophy, like myopia. And here is also very important sign, like the cytomegalovirus. There is absence of inflammatory cells in the vitreous or the aqueous. This occurs also in immune suppressed patients. So you are unlikely to find inflammatory cells in the anterior chamber or in the vitreous. Subretinal hemorrhage, fluid, or scarring due to choroidal neovascularization. This is one of the complications reported in patients with presumed ocular histoplasmosis that can be treated. So we need to follow up those patients, because if they develop CNV, then it can be treated by anti-VEGF injection, which can improve the vision. Let's now move to the non-infectious posterior uveitis. One of the commonest diseases that will cause non-infectious posterior uveitis and panuveitis is the Behçet disease. Behçet disease is a chronic, recurrent, multi-system condition characterized by the main pathology here in the blood vessels. It will cause inflammation of the blood vessels and vasculitis, occlusive vasculitis. What will be the diagnostic triad? It will be the oral ulcers, genital ulcers, and inflammatory eye disease. So if we are suspecting the patients with Behçet disease, we need to inquire about the history of oral ulcers and genital ulcers. Associations with HLA-B51 and B5. This is also have been asked very frequently in the exams. So to remember it, so it will be the HLA-B51 and B5. Please don't forget it. And it will be more common in males than females, more commonly in young adults, more common in the Japan and the Mediterranean countries. So Behçet is the Turkish doctor who discovered this disease. So this disease is more common in the Turkey and the Mediterranean countries, and also in Japan. So remember, this is the second time we say about Japan, and the first time was in the Kawasaki disease. So what will be the ocular features and systemic features of this condition? The ocular features, those patients will have uveitis, which will be posterior more commonly than anterior. This uveitis is non-granulomatous anterior uveitis, usually bilateral, with a transient hypopyon, a mobile hypopyon. Those patients will have recurrent vascular occlusion, retinal hemorrhages, exudates, cystoid macular edema, vitritis, traction retinal detachment, and ischemic optic neuropathy, and also can develop cataract and glaucoma. Systemic features are very important and will help very much in diagnosis of this condition, like the oral ulcers, or what's called aphthous ulcer, the genital ulcers, the presence of skin lesions such as erythema nodosum. Those who are applying for the FIBO exam, the Fellowship of European Board exam, they present to them this leg photo and asked that this patient has uveitis. So they asked about the erythema nodosum, which occurs with the Behçet disease. There will be also acne-like lesions and folliculitis. There will be arthritis involving the wrists and ankles, thrombophlebitis and large vessel occlusion. Those patients even can present up to with the inferior vena cava obstruction. due to thrombophlebitis. GIT pain, diarrhea, and constipation. CNS involvement such as meningoencephalitis, what's called the neuropathy, stroke, pulses, and confusional state. Also, there is something called the positive pathology test. I don't know why I didn't write it. Let me. Positive pathology test. What is the positive pathology test? It is when we are injecting, when we are like when puncturing of the skin by by a 2070 gauge needle, by a sterile needle, this will result in formation of a pustule within 48 hours. So again, puncture of the skin by a sterile needle, by a hypodermic needle, this will result in pustule formation within 48 hours. This is called the positive pathology test. The treatment of Behçet's disease will be by systemic steroid cytotoxic agents such as chlorambucil, which will be most effective for retinal vasculitis and the meningoencephalitis. Colchicine will prevent the recurrence, and cyclosporin for controlling of the acute attacks. Other disease characterized by non-infectious posterior uveitis and panuveitis called the Vogt-Koyanagi-Harada syndrome. Vogt-Koyanagi-Harada syndrome is a bilateral diffuse granulomatous panuveitis characterized by the presence of serous retinal detachment, disc edema, meningeal irritation, skin pigmentary changes, and auditory disturbance. So it will be a systematic disease affecting the eye and the other body systems. However, in some occasions, it can affect the eye only. So there will be only panuveitis. And in this case, we call it a Harada disease. Only Harada disease if there is only eye findings. What is the problem in the Vogt-Koyanagi-Harada? This is an autoimmune disease that will affect the tissues containing melanocytes. That's why it will cause skin pigmentary changes. It will affect the hair and also would affect the retinal pigment epithelium. It typically occurs in Asians, Americans, Indians, and Hispanics, and also occurs in Moroccans, those who are from Morocco. Occurs between age of 30 to 50 years old and more in females than in males, and also associated with the certain HLA types, HLA-DR4 and HLA-DW53, also asked before in the exams. What will be the systemic features in those patients? It will affect there is auditory disturbances. So it will be, there is temporary deafness, there is tinnitus, vertigo, meningeal irritation, and skin changes such as alopecia, vitiligo, and poliosis. So those should be also checked if we have suspicion of Vogt-Koyanagi-Harada syndrome. Regarding the ocular features, those patients will have decreased vision, pain, redness, and photophobia from anterior uveitis. Also, they will have bilateral diffuse granulomatous panuveitis. Bilateral diffuse granulomatous panuveitis with serous retinal detachment, vitritis, exudative choroiditis, ciliary body detachment, cystoid macular edema. They will also have a characteristic feature called the sunset fundus. You see this depigmentation due to affection of the RPE. It will result in sunset glow fundus. Also, there will be some granulomas called the Dillon-Fox nodules, appears as yellowish white retinal spots, but usually this is a late finding, so don't depend on it for diagnosis. It will present late. Dillon-Fox nodules, optic nerve hyperemia and edema, and poliosis, and later on there will be some whitening around the limbus called the perilimbal vitiligo or Shigura sign. Perilimbal vitiligo or Shigura sign, this also occurs later on in Vogt-Koyanagi-Harada syndrome. The investigations or diagnosis depends mainly on the clinical features, and investigations to confirm we can do lumbar puncture to find the CSF pleocytosis, and treatment should be initiated by systemic steroids and cytotoxic agents. Another disease which is very similar to the Vogt-Koyanagi-Harada syndrome and the most important differential diagnosis to it, but with a history of trauma, it will be the sympathetic ophthalmia. In the sympathetic ophthalmia, this is again a bilateral granulomatous panuveitis, but in this case, it will be following penetrating eye trauma. Why we are calling it is the similar like Vogt-Koyanagi-Harada, because it is the same pathology. Like there is a destruction of the melanin in the body or in the tissues containing melanin, including the uveal tissues. But here in the sympathetic ophthalmia, this is due to sensitization of the immune system to the melanin or melanin-associated proteins in the uveal tissues. And this kind of immune reaction, it is a T cell mediated or what's called delayed hypersensitivity reaction. It doesn't always to occur after the trauma immediately, but it can occur from few days up to 50 years from the injury. It has an incidence of low incidence of about 0.1 to 0.3% of penetrating injury, and much less low percent or low ratio after the intraocular surgery, about 0.015% of intraocular surgery. Have been also linked to HLA types like HLA A11 and DR4 like Vogt-Koyanagi-Harada. And clinically, it will be present with the same clinical features of Vogt-Koyanagi-Harada, like the presence of iris nodules such as Kopay nodules, mutton fat capes, as any granulomatous uveitis, retinal edema, Dylan-Fox nodules also may have disc edema, but here is the striking feature or the striking difference. Not only the history of trauma will differentiate between it and the Vogt-Koyanagi-Harada, but also the sparing of the choriocapillaris. In sympathetic ophthalmia, there is a sparing of the choriocapillaris. They don't show any signs of inflammation, but in the Vogt-Koyanagi-Harada, there will be involvement of the choriocapillaris. Treatment will be the same to initiate by steroids or immunosuppressives, and we can consider enucleation of the injured eye within 10 to 14 days if the vision is no PL. So if the vision is no PL in the injured eye, we can do enucleation for it within 10 to 15 days. However, if the inflammation has already started in the other eye, then the removal of the injured eye can be controversial. Some would say that it is non-seeing eye, so better to remove, and the other will say once the inflammation started, the removing of the eye will not stop it. Okay, so Dr. Yusuf, what do we see when the choriocapillaries are involved? There will be chronic granulomatous inflammation. The same, the epithelial cells, and the giant cells. So they will be present or in affecting the choriocapillaris in the Vogt-Koyanagi-Harada, unlike the sympathetic ophthalmia. Another very important disease, which is non-infectious posterior or panuveitis, it will be the sarcoidosis. So sarcoidosis is a multi-system granulomatous disease characterized by non-caseating granuloma. So there is no caseation, no necrosis in the center. It has an unknown etiology. Nobody knows why sarcoidosis happens. It is again more common in females than in males, and it's more common in the African American. It will be like 10 to 1. This is very important and asked also in the MCQs. African Americans, remember, African Americans also have high risk of open angle glaucoma, primary open angle glaucoma. Sarcoidosis is also one of the diseases that are more common in the African Americans. 25 to 50% of patients have systemic sarcoidosis, and ocular diseases. Regarding the ocular diseases, 30% are unilateral, 70% are bilateral, 40% are acute, 60% are chronic. That's why you remember in the slide of acute slide of differential diagnosis of anterior uveitis, we said that sarcoidosis present with anything, with any, can be present acutely or chronic, unilateral or bilateral, in young or in the old, with granulomatous or non-granulomatous, everything. So what will be the ocular features? It depends on what will be the course. In the insidious sarcoidosis, those patients will have pulmonary involvement in the form of cough, dyspnea, extrapulmonary complications. But if the patient has acute sarcoidosis, it may take one of the two forms or two syndromes, the Lofgren syndrome or the Herford syndrome. In the Lofgren syndrome, those patients will have acute fever and arthralgia, again, erythema nodosum, viruous skin lesions called the lupus perineo, and hilar lymphadenopathy in chest X-ray. The other acute presentation of sarcoidosis will be the Herford syndrome. In the Herford syndrome, the patients will present acutely with fever, uveitis, parotid enlargement, and facial palsy. So these are the manifestations. What, or the presentation? What will be the signs? In the anterior segment lesions in the sarcoidosis can be present with conjunctival granuloma. So there could be sarcoid granuloma under the conjunctiva. It's also one of the commonest causes of lacrimal gland enlargement. Lacrimal gland involvement and dry eyes is one of the commonest presentations of sarcoidosis, and we also mentioned it in the dacryoadenitis. Remember, in the oculoplastic section, we said that it can be chronic non-specific inflammation or can be due to sarcoidosis. In acute cases, they will present with acute non-granulomatous irid cyclitis. This is mostly in young patients with acute sarcoid. But if the patient has chronic sarcoidosis, or if the patient is older age, they will present with chronic granulomatous uveitis. So again, the presentations depend on the onset, course, and the age. If the patient present acutely and he is young, it will be more commonly to be non-granulomatous. If the patient is old and present with insidious or chronic sarcoidosis, it's more likely to be granulomatous. So these are the anterior segment. Regarding the posterior segment lesions in sarcoidosis, it will be present with subtle periphlebitis. There will be like occlusion, venous occlusion, and venous sheathing like that. It will be exudation around the veins, what's called the candle wax dripping, like that. Can be retinal and periretinal granulomas, choroidal granulomas, peripheral neovascularization, vitritis, and snowballs or optic nerve head granulomas. So granulomas everywhere. The treatment will be steroids and immunosuppressives, but the most importantly is what will be the investigations. Different investigations, or like we escalate the investigations depending on the case and depending on the clinical suspicion. So we classify, or we classify the investigations into 3 triads, depending or based on the invasiveness. The least invasive will be, and maybe the least accurate, will be the first triad, like chest X-ray. In chest X-ray, it will be abnormal in 90% of cases. Also, we measure the serum angiotensin converting enzyme levels, because activated macrophages with sarcoidosis tend to secrete angiotensin converting enzyme. Also measuring the serum and urinary calcium level. So those patients tend to have abnormal high calcium, abnormal calcium metabolism. If the first triad is negative and we still have high index of suspicion to sarcoidosis, then we move to the second triad. It will be chest CT or MRI, which tend to be more sensitive. Gallium scanning of the head, neck, and chest, because it will show increased uptake in case of sarcoidosis, and pulmonary function tests. If we still, those are negative, and the clinical syndrome is still pointing to sarcoidosis, we come to the highest invasive and highest accuracy. it will be the lung and lymph node biopsy, lacrimal gland, and conjunctival biopsy, and bronchoalveolar lavage. It will show increased reuptake of T helper lymphocytes. So these are the investigations we use for sarcoidosis. Okay. Let's now move to another entity which is related to the uveitis. It is called the white dot syndrome. White dot syndrome are a group of inflammatory diseases which will be characterized by multiple dots present in the fundus. These diseases are called the AMPI, or the acute posterior multifocal placoid pigment epitheliopathy, multiple evanescent white dot syndrome, serpiginous choroidopathy, bird-shot choroidopathy, multifocal choroiditis, and punctate inner choroidopathy. These diseases are a little bit difficult, so they should be always studied as a comparison, like I'm showing you right now. So let's see how can we differentiate between these diseases in the form of the age, the sex, the laterality, the human leukocytic antigen association, vitritis, lesions, the macula, the prognosis, and the treatment. First of all, the acute posterior multifocal placoid pigment epitheliopathy. This is a disease which occurs usually in young age, between 20 to 40. It will be like similar between males to females, or slightly more common in females. Usually it occurs after a prodroma of viral illness. It is bilateral, associated with the HLA-B7, HLA or DR2. It has mild vitritis, and the lesions appears as large geographical grayish-white shallow lesions. These are the lesions appears as a little bit of depigmented lesions, large with fuzzy edges or pale or not well-defined edges, present usually at the posterior pole, and usually it appears within 1 to 2 weeks from the starting the condition. In the macula, rarely those diseases can cause choroidal neovascularization. The diagnosis will be made on the base of the fluorescein angiography, which will show very characteristic pattern. It will show early hypofluorescence. These lesions will show early hypofluorescence, but in the late frames, it will show late staining. Early hypofluorescence with late staining. This disease usually has a good prognosis. It will usually tend to recover, and even with no treatment. So I think that this will be even the best one of all the white dot syndromes. It is acute posterior multifocal placoid pigment epitheliopathy. So every letter here or every word counts for a specific feature. It is presenting acutely, present posterior pole. It is multifocal, present with multifocal lesions. Placoid, it will take like a form of plaque, so it will be like disc-shaped. Pigment epitheliopathy, it will be, the affection will be at the level of retinal pigment epithelium, or will be inflammation of the retinal pigment epithelium. Okay, the second disease is called the multiple evanescent white dot syndrome. This disease tended to occur at older age group. So it can occur up to 50 years old. It is more common in females than in males, and it tends to have an insidious onset. This is very, very important. Insidious onset. This disease doesn't present acutely, but insidious onset. It is presenting unilateral, no HLA associations, mild vitritis, and the lesions are small, soft grayish white dots with no scarring. And when you see the macula looks like granular, but also the CNV is rare. When you do the fluorescein angiography, you will find that there is early punctated hyperfluorescence. There is early punctated hyperfluorescence that will take what's called wreath-like pattern. This is the wreath-like pattern. You see here the wreath-like pattern. This bouquet or maybe of flowers or decoration, it will be the same like pattern, wreath-like pattern. So early hyperfluorescence in a wreath-like pattern and late staining. So late staining occurs in areas corresponding to the presence of these white dots. Also, there is a very common feature that can be present, which frequently asked in the exams, that those patients can present with acute idiopathic blind enlarged acute idiopathic blind spot enlargement. If you revise the first lecture that we mentioned discussed in this course, where we discussed the neuroophthalmic visual field defects, we said one of the causes of enlarged blind spot is multiple evanescent white dot syndrome. This is idiopathic, acute idiopathic blind spot enlargement. Okay, the prognosis is good, no treatment also is required. The third condition is called the serpiginous choroiditis or serpiginous choroidopathy. This disease affects the between 30 to 50 years of old. It will be males to female ratio will be 1 to 4, and it is tend to be bilateral with associations with the HLA-B7, mild vitritis, and the lesions will show active geographic-like lesions. Geographic-like lesion or serpiginous lesions with grayish-white patches, and it will cause deep scars with fibrosis. So that's why the prognosis is poor, because it will cause fibrosis. So the active lesions here in the fluorescein angiography will show early hypofluorescence. So there is early hypofluorescence, but with late leakage. Okay, so early hypofluorescence with late leakage. Here is the leakage, here is the leakage. Okay, so this is the how does the serpiginous choroidopathy appears. Those patients will have poor prognosis. They can show subretinal scars and choroidal neovascularizations develop within 25% of cases. And the treatment should be initiated by steroids. Another condition called the white dot syndrome or birdshot retinochoroidopathy. In the birdshot retinochoroidopathy, it occurs in between 40 to 60-year-old, common between females and males, and more commonly bilateral with the HLA A29. This is also asked commonly in the exams, A29. It has a chronic vitritis, moderate vitritis, with deep creamy spots with indistinct margin, yellow scars without pigmentations. And the fluorescein angiography, this is not fluorescein angiography, by the way, this is the indocyanine. This is the indocyanine angiography. It is better for these lesions, but the fluorescein angiography will show hypofluorescent lesions with also late staining. I don't remember. Okay, so the fluorescein angiography will show hypofluorescence with late staining, subtle late staining, and the ICG here or the indocyanine angiography will be better to show these lesions. The macula can show cystoid macular edema with rarely choroidal neovascularization with poor prognosis and treatment by steroids and immunosuppressives such as cyclosporin. The other condition is called multifocal choroiditis. It occurs between 20 to 50 years old, more common in females than in males. The HLA, no HLA associations with chronic moderate vitritis. Lesions will be multiple grayish white yellow spots with old scars and new spots. The fluorescein angiography here will show late staining of these choroidal lesions. So there will be early hyperfluorescence, minimal early hyperfluorescence with late hyperfluorescence and staining. Also, those patients could have cystoid macular edema with choroidal neovascularizations occur in 35% of patients, and fair prognosis with response to steroids and anti-VEGF for the choroidal neovascularization. Finally, the punctated inner choroidopathy. So it occurs between 20 to 40 years old, more common in females, no HLA associations, no vitritis, multiple yellowish grayish opacities present in the posterior pole, as you can see here, punched out scars, with the macula showing atrophic scars with 40% incidence of CNV, with good prognosis, and treatment should be done for only the CNV if develops. Regarding the fluorescein angiography, will show early hyperfluorescence. Here, there is early hyperfluorescence with variable or late staining of these lesions. Also, if there is cystoid macular edema, which will be present. If there is CNV, it will manifest as late staining. Okay, so these are the white dot syndromes and the characteristic feature of each one of them. And let's now talk about the final part of our lecture, which is the treatment of uveitis. So treatment of uveitis there are many factors that will control the treatment of uveitis. So the treatment of uveitis depends mainly on the anatomical location of the inflammation, like whether it is anterior, intermediate, or posterior, or panuveitis. It will also depend on the clinical disease severity, whether it is mild, moderate, or severe, the disease duration, whether it will take months or years, and the likely etiology, like if it is infectious, so it will need antibiotics, and also the related complications, like if the patient has cataract or glaucoma or band keratopathy. Also, the patient, if the patient has any comorbidities, like if the patient has associated systemic disease, like renal problem, liver problem, so this also should be taken into consideration for some contraindications for certain classes of drugs. To just group the medications into 4 categories, the treatment options can be mydriatics and cycloplegics, antibiotics for infectious cases, immunosuppressives, and steroids. Let's start by the mydriatics and cycloplegics. Why we give mydriatics or cycloplegics for the patients? This is for 3 main reasons. First of all, to promote the comfort, to relieve the spasm of ciliary muscle. So the patients with inflammation, they will have spasm of ciliary muscle, and we need to relieve this spasm by mydriatics and cycloplegics. Prevention of formation of posterior synechia by making the pupil always in a mobile state, constriction and dilatation, leading to preventing any posterior synechia, and the breakdown of recently formed synechia. What will be the drugs that can be used? They can be short-acting or long-acting. The short-acting will be the phenylephrine, the tropicamide, and cyclopentolate. And the long-acting will be the homatropine and the atropine. Regarding the other medications such as steroids, how can we administer steroids for those patients? It can be different ways. It can be either topical, can be intravitreal, can be periocular, or subtenon, or systemic administration such as oral or intravenous. So all these are the routes for steroid administration. The administration or the route will depend mainly on the anatomical location. So regarding, so we have the topical, the subtenon, the intravitreal, or the systemic. In cases of topical or anterior uveitis, the main treatment is by topical medication. So topical will be the mainstay of topical steroids will be the mainstay of anterior uveitis. So the anterior the steroids will reach good concentration in the anterior chamber and help to manage the case. However, we can consider other modalities. We can consider subtenon or intravitreal or systemic steroids if the patients or in some occasions, for example, if the patient has severe uveitis or if the severe of the uveitis is not responding to the topical treatment. So severe unilateral anterior uveitis, we can consider periocular steroids, or anterior uveitis with a hypopyon, or if there is anterior uveitis complicated by cystoid macular edema, as in cases of chronic anterior uveitis in juvenile idiopathic arthritis, we said that it will have cystoid macular edema, so we can consider intravitreal or subtenon. Or we can use it like if there is we can use the topical if there's contraindication for systemic in case of posterior uveitis, but we will come to that in posterior uveitis. It was asked before in some exams about the potency of the steroids. So if we wanted to measure the potency of the steroids on a scale where the hydrocortisone is the minimum, so it will be like having a scale of 1. So each steroid has how many folds of the potency of hydrocortisone. So the betamethasone will be the strongest steroid, the most potent steroid, around 33% or 33 times like the hydrocortisone, followed by the dexamethasone 26%, methylprednisolone 5 times, not percent, 5 times, triamcinolone 5 times like hydrocortisone, prednisolone or the difluprednate 5 times like the hydrocortisone. And the difluprednate is like defluorinated derivative of the prednisolone with potent anti-inflammatory activity. So it was just manufactured to be more potent than the prednisolone, so that it can be given at less frequency. Prednisone 4 times and the hydrocortisone, and the hydrocortisone will be the minimum. Okay. In the intermediate uveitis, we can use the subtenon and the intravitreal. So these are the subtenon or the periocular steroids, or intravitreal. This will be the use for the intermediate uveitis, together, of course, with other treatment like cryotherapy or laser phytocoagulation or parsopona vitrectomy or immunosuppressive medications if needed. And also it needs to be mentioned that in intravitreal triamcinolone acetate, 50% of patients will develop high intraocular pressure. We mentioned that in the glaucoma lecture. Don't forget, intravitreal triamcinolone acetate, 50% will develop high intraocular pressure, and usually it will develop 2 weeks to 4 weeks after the injection. Okay. So the main route is in the intermediate uveitis is the subtenon and the intravitreal injection. Regarding the posterior uveitis, it is mainly by systemic steroids. So systemic steroids will be the mainstay for posterior uveitis, can be aided by periocular or intravitreal steroids, but the systemic will be the main treatment. Regarding the antibiotics, so there will be specific antibiotics depending on each case, as we mentioned in the lecture. Regarding the immunosuppressives, there are the immunosuppressant. These are the immunosuppressants like azathioprine, methotrexate, mycophenolate, mofetil, mycophenolate sodium, and cyclosporin, sirolimus, tacrolimus, chlorambucil, cyclophosphamide. These are the main immunosuppressives, and these are their mechanism of action. There are side effects that also you should be aware of. Let me summarize the most important. So the azathioprine will cause bone marrow suppression. Methotrexate will cause bone marrow suppression and hepatotoxicity. Mycophenolate will cause bone marrow suppression. Cyclosporin, very important, nephrotoxicity, hepatotoxicity, gingival hyperplasia, and hypertrichosis. Very, very important, and this is the most commonly asked in the exams. Cyclosporin will cause toxicity to the liver and the kidney, causing enlargement of the gingiva, and also cause hypertrichosis. Tacrolimus also will cause neurotoxicity, hepatotoxicity, and nephrotoxicity. Chlorambucil, bone marrow suppression and hepatotoxicity. Cyclophosphamide, bone marrow suppression, and hemorrhagic cystitis. This is very important. Cyclophosphamide is a drug used in Wegener granulomatosis or polyangiitis, or the Wegener granulomatosis. This is the side effects of the drug. It will cause hemorrhagic cystitis. An easy way to remember the side effects of some immunosuppressive medications is used by the chemo man. So the chemo man is a nice man. He has this is his head, his ears, his hands and feet, his arms and legs, his kidneys, bladder, heart, and lungs. So remember, these lungs are B for bleomycin. Bleomycin is an is an anti-suppressive or immunosuppressive medications that can be used for intralesional injection in basal cell carcinoma, and it will cause pulmonary fibrosis. So remember this B for lungs, pulmonary fibrosis. D is the doxorubicin, is another immunosuppressive drug which can be cardiotoxic. C for the cisplatinum or carboplatin, which can be used for and as immunosuppressive for retinoblastoma. They are causing nephrotoxicity and also ototoxicity. MF or methotrexate and the 5-fluorouracil, methotrexate and the 5-fluorouracil, causing myelosuppression or bone marrow depression. C for the cyclophosphamide, they will cause cyclophosphamide can cause here P are causing hemorrhagic cystitis. So it's present here at the site of the bladder. And V is the vincristine, which is also used for the retinoblastoma, is causing peripheral neuropathy affecting the hands and feet. So it will cause peripheral neuropathy. Okay. So this is like a way to try to remember the side effects of the immunosuppressive medications. The most importantly, which was asked before in the exams, is cyclophosphamide causing hemorrhagic cystitis, and also the methotrexate causing bone marrow depression. So this is a very, very important. Okay. So that's it. This is the end of the uveitis. Thank you for your attention. Any questions?